second molar, so it's the parotid duct, and where it empties and releases the saliva out is near the upper second molars on the right and left side. So that's two of the glands. Remember, there's three pairs of glands that we have. So the parotids. We have a submandibular gland, which by the name tells you it sits under the mandible, under the jawbone, the lower jawbone. So it sits under the mandible, submandibular. This one is going to drain through a submandibular duct. The ducts are named after the glands. And this one is going to now empty behind the lower central incisors. So it's another one. Name tells you where it's located, name of the gland, name of the duct. Now I know some of you have some aspirations of going into dental hygiene or to go to the dentistry field. There are older names to these ducts. I'm going to be honest, I forgot them. I mean, it's been so long, we tried to get rid of them. There's one, I don't know which one. One of these is Wharton's duct, another one is Stenson's duct. I don't even remember. That's so old, but again, you might see it in the, the dental hygiene program, or if you're going to a dentistry, you'll see it. But again, we have the parotid gland and then the submandibular. And again, just taking a quick look at the picture, the parotid gland is right here. Sits anterior, inferior to the ear. It's the largest of the three. You can see the parotid duct draining, and it's going to release the saliva near the upper second molar and maxillary molar on the right and left side. The submandibular gland, we can see in the picture here, submandibular under the mandible. There's a duct that travels out called the submandibular duct, but it actually goes through, it actually pierces through the sublingual gland, and then it releases the secretions behind the lower central incisors. In the prior picture, why the tongue was lifted here was to show you underneath the tongue, along the frenulum, are the openings to the submandibular gland. So the saliva from that gland, the second one that I listed here, is going to be released right behind these lower central incisors. And sometimes when you go to have your teeth cleaned, be a dental hygienist or a dentist, that spend a little extra time up on the side over here, and certainly behind your lower teeth where you tend to build up some plaquing and calculi there. So that's the submandibular gland. Just as an aside, not for testing purposes, because you don't see it anymore, but for folks my age, when you were maybe about 7 years old or so, you're in second grade or something like that, you wake up one morning, you look like a chipmunk. And all puffed up over here, your parotid glands had an infection, keratitis, or what they more commonly refer to as mumps. When you got mumps, it was an infection of the parotid gland. You look like a chipmunk. It wasn't overly painful. You got to stay home for a couple of days, which was always nice. You wants to go to school when you're a kid, and you get to stay home. But now they have the MMR vaccine, the measles, mumps, rubella vaccine, so you don't deal with that too much. Sublingual gland, once again, name tells you exactly. Sub deals with something that's under. Lingual deals with something that's under the tongue, so it sits under the tongue. And these strain through, there's a bunch of small little ducts they're referred to as lesser sublingual ducts. I'm not exactly sure why they call them lesser sublingual ducts, because there really are no greater sublingual ducts, so I should just call them the sublingual ducts. And this is just going to empty onto the floor of the oral cavity. So 3 different glands producing the saliva, releasing it into the oral cavity at that point. We do produce saliva throughout the day. You're producing some right now. Obviously, you make more saliva when you're eating. The thought of food, the sight of food, smelling the food, tasting the food will stimulate the brain to signal salivary glands to increase the production of saliva. Saliva itself, if we look at what is saliva, it's like most of the secretions of the body. Saliva is mainly water. It's at 99.5% water. It's a water secretion-based secretion that we have there. There's the other 5%, that 0.5%, just a half of a percent. The other 0.5% is what we refer to as solutes. And the solutes that we have in there, there's a couple of interesting ones that we have there. We do have some chlorine in there. So there are some chlorine ions in there that we find in the saliva. Saliva also has as part of it, there are antibodies, IgA, immunoglobulin A, that you learned about in Anatomy 1. Immunoglobulin, the fancy name for an antibody, and in the secretions of our own bodies, we have some secretions that have IgA in it, and we do find that in the saliva. The saliva, I mean, the mouth is one of the entrances into the body. We need to protect it. Just as I said, IgA is also what's found in breast milk. When a woman breastfeeds a baby, God bless her, she has IgA in the breast milk, and she's able to give natural passive immunity to the baby, passing on her antibodies to the baby. Also, we'll find in here something that's called salivary, because it's in the saliva, obviously, amylase. Salivary amylase, talk about in just a moment. It's an enzyme actually involved with digestion. It'll start digestion. We'll be talking about in just a few minutes. So that's what we have in the saliva and such. Overall, saliva, I mean, we don't think much about it, but it does. Technically, saliva has 5 different functions. There are 5 functions to saliva. One of them is that it's going to moisten. It moistens. The oral cavity is lined with a mucous membrane. It needs to remain moist, and so the saliva, as I said, we produce it throughout the day. You're even making small amounts of it right now, not as much as if you were having a slice of pizza right now or something, but it moistens the oral cavity. It also helps to cleanse to an extent. I'm not going to bite you. I don't want you to bite me. It's not that clean the mouth, but it helps to cleanse because we're producing it throughout the day. Whatever's in our oral cavity, it's swallowed, goes down to the stomach where the acids just decimate anything in it. So it moistens, it cleanses. It also is very important. It lubricates when we swallow. It helps us with swallowing. It lubricates when we swallow. It's also involved with something that's referred to as gustation. You've taken Anatomy 1, you already know in sciences we love to take the simplest things and make them sound so complex and technical. I'm sure someone has a very good vocabulary in here. Some of you have the Merriam-Webster's app on your phone and you don't just use it. No, so anyhow, gustation. Somebody. What do you think gustation is? Sense of what? Taste, yeah, sense of taste. Yeah, it's the fancy term for sense of taste. And then it's also with that salivary amylase, what it's going to do, it's going to initiate carbohydrate digestion. Carbohydrate digestion begins in the oral cavity. When we chew the food and we mix it with the saliva, it's going to allow this salivary amylase that I mentioned earlier to begin to act upon carbs and or the bonds between the carbohydrates that we have. So it really has 5 functions. In New Jersey, there's a 6th one. It's spitting at somebody that's cut you off and you're driving it. It's a whole different thing. Anyhow, a little bit about the salivary glands, and again, the pictures that I had up before. We can see there's 2 of these parotid glands, 2 submandibular glands. Here's the sublingual glands. They sit just underneath the tongue, and there's a number of little ducts that they have. We call them lesser sublingual ducts, and we can release the saliva into the oral cavity. Again, the amount of saliva that we release will vary, from time to time. You're producing a small amount now, you're eating a good meal, you'll produce more. If you're going for a job interview or you're in the middle of taking an oral test or something, you'll produce a lot less because you'll get nervous, you'll go into fight or flight, you'll make less, and your mouth gets all dry and pasty. So it does vary throughout the day, the amount of saliva that we produce. So salivary glands, so one of the accessory structures that we have in the oral cavity. Let's take a look at another accessory structure. I'm not going to say a lot about it, but we'll mention it, and that would be the tongue. The tongue is an accessory structure found in the oral cavity. Obviously, we use the tongue for other reasons other than digestion. When we speak, we use the tongue for pronunciation and enunciation. There's certain ways we have to move the tongue, but we do use it obviously with digestion. We have to mix the food with the saliva. The tongue allows us to mix the food. It's involved with the swallowing mechanism. The tongue is obviously made up of skeletal muscle. We do have control over the tongue, voluntary control over the tongue. I still remember my grad school professor, Dr. Bowden, always used to, his funny thing was he was just the most muscle in the body. But he was just talking about what you can do with your tongue. You can basically kill people with your tongue. You can lift people up. You can do things with your tongue in the sense of it can be kind of dangerous when you say things that you shouldn't say. But the tongue, it's skeletal muscle. It's interesting. The tongue, it has really like two types of skeletal muscle. Some of them are very, very short fibers that are found in the tongue itself. Those are referred to as intrinsic muscles. They're still skeletal, but they're intrinsic. And then we have some that are longer. They run from the mass of the tongue, and then they go beyond the physical tongue itself. They're called extrinsic muscles. The intrinsic muscles are the muscles that are involved with changing the shape of the tongue. So they can change the shape of the tongue, and we would change the shape of the tongue for both speech and for swallowing purposes. We have to change the shape of the tongue. The extrinsic muscles are the ones that give us more of a gross movement, a larger movement of the tongue. So when you were a kid and you stuck your tongue out at your brother or sister, or they did that to you, that was the extrinsic muscles that are doing that. So they allow us to move the tongue in and out, side to side, whereas the intrinsic are going to get smaller little changes. It's a genetic trait, actually, that some of you have, some of you don't have. If you're able to roll your tongue, where you can curve your tongue around and roll it, that would be the intrinsic muscles that are doing that. You just happen to have the genetics to do that. We're going to talk a lot more about the tongue later in the semester in chapter 17 when we discuss special senses, sense of taste, but I do want to mention a couple little things. The dorsum of the tongue, that's the upper surface. So if you were to look in a mirror and stick your tongue out and look at the top of it, we call that the dorsum. You can't really see this per se, but on that dorsum of the tongue, we have these structures called papillae. They're little elevations. The little elevations that we have here, these papillae. If anybody here happens to have a cat, a feline companion around the house, you're familiar with it. They have very prominent papillae. When a cat licks you, usually, it feels like sandpaper. They just have very, very prominent papillae. We don't have that level of elevations. As adults, you have three types of papillae, but we're born with a total of four. There is a papillae that's called the foliate papillae. The foliate papillae, they degenerate as we get to adulthood. So we don't have them. You won't have them here. So these eventually degenerate, and we don't have them. But the three that we have as adults, these you'll find in adults on the tongue, on that upper surface. We have one that's referred to as filiform papillae. That's one type, filiform papillae. And again, we're going to look at this more in chapter 17 when we talk about taste, because it comes into play. There's another type that are called the fungiform. And there's a third type that are called vallate, V-A-L-L-A-T-E, vallate papillae. So there's filiform, fungiform, vallate papillae. That's what all of us have. You did have foliate papillae off way on the side. We had them when we were children, but over time they degenerate. And the whole purpose of the papillae overall is really to provide a certain amount of friction. We want to have a bit of friction on the tongue, so when you put your food on it, it doesn't fall back off onto your plate. So when you were eating your Eggo waffle this morning, you were able to keep it in your mouth as you were chewing on it. Of these three adult forms of papillae that we have, these two, the fungiform and the folate, are the ones that contain taste buds. They have taste buds in them, the fungiform and the vallate. The filiform rarely have, they can, but they rarely have taste buds associated with them. So when we chew our food properly and we use the tongue to mix it around with the saliva, which we make more when we're eating, allows the taste molecules to get into the saliva, and then the saliva will be carried down into the taste buds where we're able to stimulate the gustatory receptor cells, and we pick it up as taste. So for most of you, I'd say not most, all of you, if we took things, obviously I don't want you to be allergic to things, but if we took things that had maybe a similar texture where we could blindfold you, so we take a banana, kind of mush it up, and take an avocado, mush it up, texture similar, so we're not, you're not picking it up by texture. You say, well, yeah, I can taste the avocado, that's the banana, that's an orange versus a grapefruit type of thing. They get down into the taste buds, and then we're able to interpret it. So just want to mention a little bit, we're not going to spend any other time on the on the tongue at all, but it is an accessory structure, very, very important for the mixing and the movement of the food. It is involved with the swallowing mechanism. The other accessory structures that we have you're familiar with would be the teeth. We have the teeth, which are another accessory structure, which is essential for digestive purposes. When we talk about the teeth, there's actually two sets that we have. We have two sets of teeth. We have a primary dentition, or the baby teeth, and then we have a secondary dentition, or the permanent dentition. So the primary dentition, we're going to take a look at these. The primary dentition, or the primary set, normally the average number that you would have is 20. That's an average number. There's 20 teeth in the primary set that we have, and then there's a secondary dentition, or you could call it the permanent dentition. There's other names for these: adult, permanent, primary, baby teeth, deciduous teeth. There's 32. So 32 teeth in your secondary adult dentition you have. Now it varies. These are average numbers. It varies. Some of you may have one wisdom tooth that just didn't push through. So you have 31, not a problem. The other one, if you looked at an x-ray, you'd see it tucked down in there, just not causing you a problem, leave it alone. In other cases, somebody may have an extra little tooth in the back behind a wisdom tooth. They call them supernumerary teeth. So you have 33 teeth that you have. So they do vary in number. It's one of my pet peeves. I'm going to talk to God one day when I get there and say, how about a third set, like when you were 45 and you really knew how to take care of them very, very well and such. You want to take care of your teeth. So anyhow, the teeth, let's talk a little bit about the teeth themselves. A tooth has three different parts to it. There are 3 parts to a tooth. One part is what we call the root or roots. It depends on the tooth. Some tooths have a root, some have roots, 2 roots, 3 roots. Others you get a tooth that may have 4 roots. The root is actually what is going to, it fits into something called the alveolar process. You got to go back in your memory banks for that to Anatomy 1, Chapter 7, when you were learning about the facial bones. And you had different facial bones, and the facial bones included the maxillary bones and the mandible. And the alveolar process, what it is, it's the hollow cone-shaped depression that are in the jawbones. Some of the skulls we have, most of them are plastic skulls, but there are a few real bone skulls still up in the labs that you probably saw, and they're missing some teeth. And you look along the jaw, it looks like an ice cream cone, not the flat bottom cone, look, the cone-shaped one. It has that depression, and that's what the teeth fit into. So the roots fit into the alveolar processes, and those alveolar processes are part of the maxillary bones and the mandible. So that's one of the parts. A second part that we have is the crown area. So the second portion would be the crown. The crown, that's the visible portion. That's the part that we see. So when you smile at someone, they're seeing the crown of the tooth. Now the crown of the tooth happens to be covered with the hardest substance in the human body. I think you're all familiar with it. You see it on commercials when they're selling toothpaste and such. This is all covered with enamel. The white stuff is the enamel. It's the hardest substance in the body. It's actually kind of interesting. It can self-repair to an extent, but it is, though it's very, very hard, it is susceptible to acids produced by bacteria, which over time will eat through that enamel, demineralizing the tooth, and we end up with we call it a cavity or a dental carie. You end up with it that way. So it does cover the tooth, the enamel. And then the third part is just sort of a nebulous region. It's hard to define or really point out, but it's something that's referred to as the neck. The neck simply is just the junction between your root and crown. This is the junction that you have that's located between number 1, the root, and number 2, the crown. So we call that the neck area. And I think I got pictures of that. Put up here, tooth. There we go. Okay, put the picture of the tooth up there. So we have a crown, we have the roots, and we have the neck area. The tooth, other than the enamel on the surface of it, the tooth primarily is made of a bone-like substance. It's made of something that's called dentin. And that dentin surrounds a hollow core inside the tooth. Inside the tooth, it's a hollow area inside. There's a hollowed space on the inside. And that hollow space inside is something that's referred to as the pulp cavity. And the pulp cavity is then filled with something that many of us are familiar with. It's called pulp. And what the pulp would be is the pulp is technically the blood vessels and the nerves. So if you've ever had any dental work or a toothache, you know that there are nerves inside of a tooth and it can hurt, and you know that there's blood vessels inside of it. So again, the tooth is mainly made of dentin. There is a hollow space inside. That hollow space is called the pulp cavity. It's filled with something that we collectively call pulp. And the pulp is really the blood vessels inside the tooth and the nerves. Now, the way the blood vessels and nerves get into the tooth, some of you may be familiar, you've heard the term before. In the roots, we find in the roots, there are little things called root canals. And the root canals are how the blood vessels and nerves get into the tooth at that point. And I can point some of these things out to you in just a sec. We'll let you copy this and I get a little bit of water. So we take a look at a tooth. I mean, we're all kind of familiar with them. So we have the root area, which is the part that fits into the alveolar bone. It fits into the depressions, the roots. Then we have the crown, which is the visible portion, and it's covered by enamel, which is the hardest surface that we have in the body. And then we would refer to the junction between the root and the crown as the neck area, so somewhere in this area here. Most of the tooth itself is made up of this tannish material here. That's what's referred to as dentin. It's a bone-like substance, but it doesn't have the form of bone, so there's no osteons and there's no concentric lamellae or any of that sort of stuff that we have. And then inside there is a hollow core inside of it called the pulp cavity, and has the pulp in there, and that's going to have nerves and blood vessels inside. Now the way they get in is at the bottom of each root, there's a little opening down here called an apical foramen. Apical just means pointed, like an apex at the pointed end. An opening, you remember the term foramen from Anatomy 1, there's an opening there. And so the nerves and the blood vessels get inside of the tooth through the root canals, and they extend inside to the pulp area over there. When someone has a root canal procedure done, the tooth is basically dead. There's a problem with it. And they'll, obviously drill through the surface. They come in, they clean out the pulp cavity, they file out the canals over here, and then they fill this up with a gummy substance inside of there and seal everything up. They do quite a number of root canals per year in the United States, but there's a lot of questions that have been raised over the past decade about the safety of them, because you basically now have a dead part of your body still in the body. And off of these root canals over here, there are numerous microscopic little channels coming off of the side of it. You can never get them all clean. And there's some thoughts that a lot of the problems that we have, people that have root canals as you get older, is because there's actually anaerobic bacterial infections inside of there going on. Yeah.
So does that mean that the nerves and the blood vessels are dead? So isn't it better to just take it out, or just also why people end up getting crowns, like crown replacement?
Yeah, she's asking all about, if everything's dead, wouldn't it be better taking it out? Yeah, that's the question. Why not take it out? Most root canals, they don't tell you anything. Most of them, they'll last maybe 10 years, and the whole tooth will collapse then, because it's a dead tooth. There's nothing there. So now you spent whatever they charge now. I don't know, today it's absorbent. I tell you, if you want to go into a field, look at a dentist. I mean, there's really not much insurance, and the insurance that they do have doesn't cover much, and they can charge you anything they want. But yeah, so the tooth decay, so you had root canal done, whatever, $1,800, you put a crown on top of it, $2,000 or something, so you spend, $3,800, 10 years later it falls apart, now you gotta go to an oral surgeon, pull out whatever's left in there, pay him or her, then you gotta put an implant in, so spend another $1,400 or $1,500, and spend another $2,000 on a crown. You could have taken it out and done the implant the first time around, and even that's changing. I mean, I have a couple of implants, and now, they use stainless steel or titanium initially, but now they've changed over to ceramic bases, which they're finding out are much, much better and safer And things change, but that's interesting. I always joke with my wife just had to have a tooth pulled, and I know the fellow, and we were chatting, and he teaches at one of the dental schools too. I said, but you're like a profession that doesn't change. I said, I feel like it's still the 1800s, and I looked at him, and he knows me, we can joke around. I said, and your guys are really, I don't know if any of you work with a dentist, or you have family members a dentist, I apologize, but they're as bad as lawyers. You can go to 10 dentists and you'll get 13 different opinions. I mean, you don't get 10, you get 13 different ways, and then they'll look at the work that the person did before. They go, I wouldn't have done it that way. You say, well, I didn't have a choice, at the time. So it's kind of interesting. There's another hand up I saw. No? Okay. So a little bit about the teeth. We can see the parts of it. These are the dentition. So if any of you have younger children or you take care of a younger child, these would be the primary or the deciduous teeth, the 20 teeth, approximately when they erupt. These numbers are not etched in stone. So, the first ones that come in there are these central incisor areas that you have. And you always see, you see a little kid, they get the little one tooth sticking up on the bottom all the time. It's the first tooth that comes in and such. And then the others make their way in. And then here's the secondary or permanent adult dentition, the 32 teeth. The last ones obviously would be the wisdom teeth, so somewhere between age 17 to 21. So some of you may be in that category. They may be erupting. I have had students through the years, and if it happens to you, I feel bad, but you don't owe me any apology. Sometimes they'll tell me you got to miss class on a certain day, and they go, I have to have my wisdom teeth taken out of something. It happens from time to time, so don't worry about it. I'm very understanding with that. And so, all right, so if we've talked about the accessory structures, let's discuss a little bit about what goes on in the oral cavity from the point of view of digestion, because the whole chapter is dealing with digestion. What are we going to do? How do we break the food down into the simple nutrients that we can absorb? So let's talk about digestion in the mouth. And as I mentioned last Thursday, as I write, my handwriting degenerates. If it does, please stop me and say, gee, what did you write? I understand it gets bad. So what's going on in the oral cavity or the mouth area in the way of digestion? Well, we're going to see in just about every part of our digestive system that there's both mechanical and chemical digestion that takes place. Mechanical digestion, for the most part, mechanical digestion, we're talking about doing something physically to what we've eaten, where chemical digestion is dealing with the chemical bonds in it. So from the mechanical point of view, in the oral cavity, the type of digestion that's taking place here mechanically is something we refer to as mastication. And once again, we always give these big fancy terms to something that's so darn simple, and mastication is just a scientific or medical term for chewing. That's all it is. When we chew our food properly, we're cutting the food, we're tearing the food, we're grinding the food, and we're basically reducing the size of it. We reduce the size, and you have more surface area so that your enzymes can work better when we do that. I mean, you folks are very young. I'm looking around here, so you probably never saw the movie Animal House years ago. But anyhow, anybody ever see that movie, Animal House? Nobody ever saw them. I can't even discuss it. As John Belushi, about a fraternity at a college, and John Belushi at one point goes down the food line in the cafeteria. He basically eats a hamburger in one bite, shoves the whole thing in and swallows it. That's not the way most of us eat. And we chew the food a little bit. And so by chewing it, we're breaking it down. We have mastication going on. And then we have chemical digestion also taking place. And chemical digestion in the oral cavity, the main chemical digestion that goes on in the oral cavity is the starch digestion. We're going to digest starch, which is a carbohydrate. It's carbohydrate. When we eat a starch, whatever it is, maybe somebody had some toast this morning, an English muffin, you had an egg or waffle, you stopped and got a bagel or something. Whatever that starch is, or last night you had some rice, pasta, and something on that level, potatoes. When we eat a starch, obviously we're chewing and it's mixed in with our food. This is where we add in that salivary amylase that I mentioned before, that enzyme that's part of saliva. Salivary amylase works like a pair of scissors. The starch itself is like a big long paper chain that you made when you were in grammar school. It's a big long chain of glucose molecules. And then we take the scissor and we begin to cut it apart. And we'll get different molecules. You will get out of the starch some molecules that are called maltose molecules. Not one, you'll get many of these. Maltose is a disaccharide. It's got two glucose molecules. This is something called a polysaccharide, the starch. It's a big long chain of glucose. Maltose is something that's a disaccharide. It's just two glucose molecules attached together. You'll also get something that we just simply refer to as trisaccharides out of it. So there's trisaccharides, which would be three glucose molecules hooked together. And then we also get something, the molecules that are referred to as alpha-dextrin molecules. Alpha-dextrin molecules. An alpha-dextrin molecule is a molecule that can be anywhere from 5 up to 10 glucose molecules attached together. So we have alpha-dextrin, and this is going to be somewhere between 5 to 10 glucose molecules that are hooked together. So I picture just taking a paper chain. If we made a big long paper chain, and I had one of the ladies in the back hold one end of the chain, and I had Vanessa down in the front hold the other part of the chain, and I just covered my eyes and took a scissor and walked along and just started snipping it. I might get two of the chains still hooked together, maltose. I might get 3 of them, a trisaccharide. I might get 6, I might get 8, I might get 9, I might get 5 alpha-dextrin molecules. But we're starting to do what I mentioned the first day, take the bagel or the toast or the rice or the noodles, whatever you were eating, and we're gonna begin to break it down toward the nutrients that we can absorb. Now, none of these, we can't absorb any of these. We've gotta complete the digestion, but we're starting the process. So this is what's going on from the point of view of digestion in the mouth. And then from here, we've now taken that food that you had on your plate, and we've taken the food that was in our mouth, and by mixing it with the saliva and chewing it, manipulating it with the tongue, we've created something that we call a bolus. A bolus is just a bowl of food. I'm not being a sexist pig or anything, but I think the ladies are probably more familiar with it because you often take care of children. And so your little niece or nephew wants to try something, they eat it, and all of a sudden they're chewing, they go, I don't like it, and it ends up in your hand, unfortunately. That's a bolus. What ended up in your hand is a bolus of food. For most of the guys, they would tell them, spit it out over there, you know, it ends up in Auntie or Mom's hand. So we now have this bolus. Now we have to move the bolus from the oral cavity, and we're gonna have to get it down eventually to the stomach. Yeah, Vanessa?
When we give kids fluid in a hospital, I think they call it bolus.
Yeah, they call it a bolus. Yeah, I'm not exactly sure where the name came from. Yeah, that's another term they use with IVs and such when they get, they talk about a bolus, but I'm not really sure where that term came from. Yes, it's the same term, yeah. So now we're gonna have to move that food from the oral cavity, and we wanna get it down to the stomach. So I just wanna mention for a moment this thing called the esophagus, because we're gonna see this come into play at this point. The esophagus is a food tube. It basically connects the throat to the stomach. So it connects the throat area, which we'll be talking about, but to the stomach. The esophagus is, function-wise, it's purely for transportation. We're not adding any enzymes. We're not doing any mechanical digestion per se. It's just really just purely function-wise. It's functioning for transportation, the esophagus. Just to move that bolus along. The esophagus, just a couple of things about it, I will say. The inner lining of the esophagus looks like your skin, except it doesn't have keratin. The inner lining of the esophagus, when we talk about it, the lining is made up of a stratified squamous epithelium. So it's a stratified squamous epithelium, so it has many, many layers. It's protecting the inside of the esophagus. We don't always chew our food completely. Some of the foods that we swallow are a little bit rough. You know, you're eating some pretzels or something, you swallow them, they're a little rough. We want to protect the inside of the esophagus. So it has stratified squamous epithelium. We'll also find a number, I'll just put a number, there's a number of mucus glands that we find in the esophagus. And the mucus glands are there primarily for lubrication. They make mucus so that we can lubricate the area for better swallowing. So I just wanted to make mention of it because we're going to discuss it now in this whole process of swallowing. So, and what we're looking at here in the picture on the board is a histomicrograph here of the esophagus wall. And mainly you get the same layers of submucosa muscularis. There's a mucosa, and you'll notice in the picture that the mucosa, the layer that's in contact with the food, is a non-keratinized stratified squamous epithelium. It's protective. Just like your skin, it's the same thing. Your skin happens to have keratin in it. Now, one thing that's a little bit different, not for tests or anything, I'm not interested in it. When I went over the different layers last time, I said you had a mucosa, you had a submucosa, you had the muscularis, the two layers, the circular and longitudinal, that's a peristoma, and I said you had a serosa on the outside. This says adventitia. It's semantics. You can only use the name serosa when you're down in the abdominal pelvic cavity and your esophagus is passing through the chest area, through the thoracic cavity. So you can't call it a serosa, so they call it an adventitia. It's the connective tissue on the outside. It's the same stuff, but we just can't use the same name with that. So let's talk about the next part of digestion, which is something referred to as deglutition. Deglutition. This is one of the reasons I'm so old school. I know some people, you probably already hate the class with me writing notes. You like to get your PowerPoint, sit there, and I have to write things, because a lot of the terms, when you write them, the names sound different. You get to see it spelled and such, and you're not flying through it. But deglutition is just the medical science name for swallowing. It's the swallowing mechanism. We've chewed the food, masticated it, we've mixed it with the saliva, and we formed a little bolus now, and now we have to move that bolus along. We need to swallow it. Now, we take swallowing for granted. We don't think about it. We do it in the car, on the go. We walk down the hallways. We're eating things, but there's actually rather complex. There are 3 different phases that are involved with the swallowing mechanism. One of the phases is something that's referred to as the voluntary phase. The voluntary phase is simply referred to that because of the fact that it's under conscious control. It involves skeletal muscle. It's going to involve the tongue. It's going to involve the soft palate. Some of the muscles at the back of the oral cavity area all get involved. But overall, what we're doing here in the voluntary phase is that what we're going to do is we're going to move that bolus. We're going to move the bolus, that little ball of food, and we're going to move it from the mouth or the oral cavity, and we're going to move it into the oropharynx. We're going to move it into the throat area. And we refer to it as a voluntary phase because it's under conscious control. Now it kind of goes smooth. I mean, when you're eating meals with your parents or something at home, you're not chewing the food, putting it in your mouth, chewing it and thinking, okay, now I have the voluntary phase. Let me consciously think about moving the food. It is conscious control, but it just kind of happens on its own. We're so doing it for so long. So we have a voluntary phase. From here we go into something that's referred to as the pharyngeal phase. And once again, it's a bolus movement. It's still conscious, but we're starting to bring a little bit of smooth muscle into play at this point. And what we're going to do now is we're going to move that same bolus that now is in the oropharynx. We're going to move it from the oropharynx, and it's going to make its way down into something called the laryngopharynx, which you learned about in Anatomy 1 in chapter 23, the other part of the throat, sometimes called the hypopharynx, and now it's going to enter into the esophagus, that food tube. So it's moving through the throat, pharyngeal phase, throat phase. We have to move it from the oropharynx. We want to move it down into the laryngopharynx or the hypopharynx, and then eventually now get it into the esophagus, into that food tube at this point. As we're doing this, there's a couple of interesting things that come into play here. One of the things that we have to deal with here is something that you learned about in Anatomy 1 in chapter 23. There's a movable cartilage flap that's found at this point between the laryngopharynx and as we near the esophagus that has to move. And I think many of you are familiar with it. What has to happen here is this structure that's called the epiglottis. It has to seal off the larynx. It has to seal off the voice box area. I think you're familiar with the word epiglottis. You've heard it before. What it does is it closes off the respiratory system, the voice box area, and directs the food down. I'm gonna show you a picture. And what it does is directs the food down into the esophagus. I mean, every person in the room here, at one time or another, you've been somewhere eating with some friends, and all of a sudden you start coughing, and they go, "Are you okay?" And say, "It went down the wrong pipe." It got around that epiglottis before it was able to shut, and then we have a reflex that wants to cough to make sure that we keep the respiratory system clean. It's happened to all of us. Usually you're in a restaurant, you're eating your salad, and the vinegar gets around you at that point, and then you're coughing a lot, you turn red, and people around the room are looking, are they okay? But that's occurring at this point in the pharyngeal phase. We have to have this take place. The epiglottis is going to move, it's going to seal off the larynx so nothing goes down into the respiratory system. The larynx is the voice box area. The reason we want this to take place is that what we need to do is we want to prevent something called aspiration pneumonia. Pneumonia is an infection in the lungs, obviously, deep in the lungs, with fluid being released in the lungs. Most of the time when we deal with pneumonia, we're dealing with either a viral or a bacterial pneumonia. But this is a little bit different. This was actually caused aspiration pneumonia by aspirating or breathing solids or liquids down into the respiratory system. I don't want any of you to get sick this semester, but if you did get pneumonia, whether it's viral or bacterial, you're gonna survive. You're not gonna be comfortable, you're gonna be survive. If you're a 90-year-old lady in a nursing home and she's having difficulty swallowing and this isn't sealing fast enough, and she aspirates either solids or liquids into the lungs and gets pneumonia, at age 90, she might not make it. It's something to be aware of, particularly when nursing students that you're going into a field. You're dealing with elderly patients. Most of the time, in most settings, unless it's some sort of traumatic injury, you deal with older patients. You don't deal with usually not a young, healthy person in the hospital. If they're young and healthy, they wouldn't be in the hospital. You get older patients, and you may notice every time I bring the food tray in for this man, he's always coughing. You make a note of it, and they don't write it anymore. It's in your little computer station. You make a note of that, and they'll get a speech pathologist in to come in and take a look at the swallowing mechanisms in this individual. You want to note all this stuff. You want to back it all up. It's unfortunately in healthcare you have to have a CYA type of mentality, which is simply you have to cover your ass. You don't talk about it now as you're thinking about going into healthcare, but every field that you folks want to go into, you have to get malpractice insurance, and you can always be sure that there's somebody out there that wants to sue you. It's those personal injury lawyers and malpractice lawyers make their entire living off of that. That's why they live in places like Alpine and Saddle River and stuff. They're always suing people. So you want to protect yourself. If you think for any reason this individual's having some problems swallowing, you note it, and you get it checked out. Sometimes it will just involve pre-cutting the food before it gets to the individual, that they're not cutting it into too big of pieces. Sometimes they use thickening agents. Some of you work in hospitals and healthcare places, and they put thicket into the soups, or they have in the coffee. I mean, the patients don't like it. It's like drinking a semi-gelatinous cup of coffee. I mean, it doesn't look very appealing, but it gives this epiglottis a chance to shut so that they don't run into problems. So that's one of the things that takes place. The other thing that has to occur here is that we need to relax something that's referred to as the upper esophageal sphincter. There's a circular muscular band in this area that we have to release or relax that sphincter in order to allow the food to move from the pharynx and get into the throat area. So we also want to relax the upper esophageal sphincter. So there's two things going on that take place during this pharyngeal phase. And then there's the third phase, and then we'll take a look at a picture, obviously. And once again, for you and I, we don't even give it a thought. This just flows voluntary pharyngeal, and then eventually we go to something called the esophageal phase. So we have an esophageal phase, and in the esophageal phase, what's happening is that we're now moving the bolus down through the esophagus. I think I joked the last time that we were together, if you've ever taken too big a bite of an apple or the pizza crust without chewing, you can please swallow it anyhow. You can get this kind of, it's an uncomfortable feeling, something moving down in your chest. Yes?
Just a question. The relax the upper
sphincter.
Is that under like epiglottis?
That's just under the esophageal phase in order for she's asking about the relaxing of the upper esophageal sphincter. It's all part of this phase. These two things are happening. You have the epiglottis sealing, and at the same time, the esophagus has a sphincter. It has to relax just to allow the bolus to go from the laryngopharynx into a question. And then we have this esophageal phase. Now what's going on here, we're just following that bolus along. We need to now move the bolus. In this case, we're moving the bolus from the esophagus. It's going to move all the way down the esophagus and then ultimately enter into the stomach when we do this. So that would be the last phase, the final phase. And this particular phase here, this is really involuntary. This is involuntary. This is really where peristalsis begins to occur. Peristalsis, I mentioned in passing last time when we were talking about the muscularis. Peristalsis is the contraction of the circular layer and the longitudinal layer of the muscularis, and it pushes the food along, much like a pastry bag would push the frosting out of the bag. It's doing that, it's pushing that food along, and it starts to take place at this point. And once again, in order to get from the esophagus to the stomach, we have another sphincter we need here to do this. We need to relax the lower esophageal sphincter. There's another sphincter. There's a sphincter at the top, and there's a sphincter at the bottom. And while you're copying it, you pull up a picture here. I know I'm moving around, and you're sitting, but is it warm in here?
Yes.
I keep bugging them. I mean, the offices above us are in the mid-80s. I don't know what the temperature is in my offices. I could grow orchids and probably kill the orchids. Anyhow, so here's the voluntary phase going to the pharyngeal phase. Let me turn the lights off a little more. So on the left, we have the voluntary phase. We can see the bolus. I don't know what they ate. Looks kind of unappetizing, but they created this bolus here. And they need to move the bolus from the oral cavity back into the oral pharynx. Now, you're going to involve the tongue with this. We're going to have to elevate the soft palate so the tongue changes its shape. And then this uvula that hangs down, that little punching bag thing that hangs down in the back of the throat area, is going to move posteriorly and superiorly. So what it's doing, it's sealing off the nasopharynx so that nothing goes up into the nose. Now sometimes things get around it, just like you can get something down the wrong pipe. Sometimes you're drinking some bubbly soda or something, and all of a sudden the bubbles go through your nose. They got up the back of the nasopharynx area faster than you could seal it off, but we can see how the bolus is moving from the oral cavity now into the oropharynx and then down the laryngopharynx. So we go from the voluntary phase here to the pharyngeal phase. The bolus is moving from the oropharynx to the laryngopharynx into the esophagus. As it does it, at this point you're breathing. Everything's the way it should be, and the epiglottis is up. The area, the air can come down here into the larynx. Here, that epiglottis has flapped over. It's covering the larynx at that point, seals off the rim glottis at the top of it, and so we don't aspirate solids or liquids. So we go from voluntary phase, pharyngeal phase, and now we're in the esophageal phase. Now the esophagus itself, if you're not familiar, it actually sits posterior to our trachea. The trachea is on the anterior surface. You have the tracheal rings. Behind that, posterior to that, where the esophagus is. As a matter of fact, chapter 23 of Anatomy 1, when you learned about the trachea has these C-shaped, maybe 16 to 20 C-shaped cartilage rings that support it. On the back, where it's the open part of the C, that's where the esophagus fits in back there. It sits in that area. You can't breathe and swallow at the same time. It's impossible to do that. So here's your esophageal phase, pushing the food along by the circular and the longitudinal muscles constricting, pushing it down, and then hopefully that lower esophageal sphincter is relaxed at this point and the bolus can enter in, yes.
Where would the upper esophageal sphincter be?
Oh, the upper esophageal sphincter sits at the junction, they don't show it here, but it's at the junction of this laryngopharynx right here at the esophagus. So at this point in here, maybe where that little dot is, it wraps around. That one usually doesn't cause much of a problem. I want to talk about, it's a good segue in, thank you. It's a good segue in. I want to talk about two medical conditions that you may come across that involve this lower esophageal sphincter. that lower esophageal sphincter, let me put it back up over here. In this area, this is the name we use, lower esophageal sphincter. It makes a lot of sense. There are older names if you're in the Surg Tech program or you're in the nursing program going through your surgical rounds and they're doing, gastric surgery. There were older names to this. One of the older names to this lower esophageal sphincter, and it wasn't bad, there was something called the gastroesophageal sphincter between the stomach and the esophagus. But then there was an older name called the cardiac sphincter. And the cardiac sphincter got its name, we'll see when we take a look at the stomach, that the first area that the food comes into is referred to as the cardia of the stomach. So they got rid of those names. Lower esophageal sphincter is fine. Now there's some condition, I'm just gonna call it the less. If you don't mind, I'm just gonna call it the less lower esophageal sphincter. This way I don't have to write it over again and again. With the lower esophageal sphincter, two interesting conditions that you may come across depending on the particular area that you go into. One of the conditions that we have is something that's called achalasia. This is a condition where that lower esophageal sphincter is too tight. It's got too much tone. It's hypertonic. The lower esophageal sphincter is just too tight. And this is something that you would see primarily if you're in nursing and you're in the neonate area, you may come across. It's not a common condition, but it's something that you might see. It's just too tight. So we have our esophagus coming down, and then it comes into the stomach, and the stomach does something like this. Over here, we have this lower esophageal sphincter here, and it's just too tight. So baby is delivered, mom's doing fine, baby's doing fine, and as they do at hospitals today, because it's all run by the insurance industry, you're not there long. Unless there's a problem, they kick you out. I mean, if you deliver at 7 a.m. in the morning, they might want you out of that place by 7 at night. Get out of here. Get out of here, go home. Take your kid home and get out of here. So they go home. Next thing you know, mom's back at the hospital at the emergency room. Yeah, because this kid has projectile vomiting. I mean, and they're spooked. And what happens is, as the baby's feeding, whether it's bottle feeding or breastfeeding, I mean, the food starts coming down into the esophagus, but this is just too darn tight over here. And because the wall of the esophagus is made up of smooth muscle with peristalsis, this begins to bulge out. The smooth muscle can stretch. We know smooth muscle can stretch. You had Thanksgiving last November. You can stretch and put a lot in things that have smooth muscle. So baby takes all of that food down, but it can't get down into the stomach. And then what happens is that smooth muscle says, oh, I have to contract now. And that smooth muscle contracts back very violently this way, and boom, comes out. And you see, not just spitting up. Kids spit up. This is projectile vomiting. All little kids spit up. You've been there. They time it too. They do it on purpose. They do it when you're all dressed, ready to go to a wedding somewhere. You're going to drop them off at grandma and grandpa's, and you got your nice dress on. Guy's got his suit and everything. You're holding a baby, and the baby burps up on your suit or on your dress. They timed it, the baby. This is different. This is projectile vomiting. This is coming out, and mom thinks she's got the child from The Exorcist here. This is something that has to be taken care of. Gastroenterologist has to get in with an endoscope and go down, and they have to stretch that sphincter to relax it a little bit. So it's not something you're going to see in an adult per se. It's more something that you might see with some children, and it's not that common. So that's one of the conditions that we have. There's a second condition, much more common, and it is something that you'll see in adults, and you probably have family members and such that deal with this all the time, and that deals with the sphincter being way, way, way too loose, and that's something that we refer to as GERD, or gastro, from the stomach, esophageal, from into the esophagus, gastroesophageal reflux disease. Now that lower esophageal sphincter is too loose. Doesn't have enough time, or it's not closing completely the way that it should close. And this is the opposite. And so we're dealing with something similar. We got the esophagus comes down into the stomach. Over here with the sphincter now is way, way, way too loose. So there's no problem with the food getting down into getting into the stomach. That's not an issue. You're not going to have this problem over here at all. It gets in. The food goes right down, not a problem. You eat the food, here goes my food, whoop, right into the stomach, not an issue whatsoever. And the stomach then begins to do what its job is, and we'll be not getting to that today per se, but what happens is it begins to produce gastric juice, and the gastric juice in the stomach has a pH of about 1 to 2. Very, very low pH, very acidic. Matter of fact, the acid in your stomach, if you could somehow